Padera. Is that correct? The last name, Padera?
Yeah, Padera is good.
Join us today to give us a talk. So Rob is associate professor at Brigham Women. Now pretty soon it'll be Brigham Women / Mass General. And he did both pulmonary and cardiovascular pathology. And I think it's interesting to me when I look at that, he studied biomaterial pathology. So one day we'll ask Rob to say what that means. But other than that, he have a lot of interest, amyloidosis, malignancy, almost all part of pathology. But in today's talk, he will focus on immune checkpoint inhibitor-mediated myocarditis. Without further ado, Rob.
All right, thank you. And yeah, I guess I can say thank you for the introduction. I saw Dr. Malashevsky on earlier, and he introduced me once as saying that I was both an engineer and a pathologist, and so therefore my social skills have got to be really top notch because of the stereotype of both of those groups. So it's much kinder than that. So I'll go through this paper. It's a review paper on immune checkpoint inhibitor-mediated myocarditis, CTLA4, PD1, and LAG3 in the heart. These are the authors here. It was in Nature Reviews Cancer recently, and it was kind of interest to me. But I'm almost more interested in hearing what other people's experiences have been with this. So my disclosures. So two of the authors, Andy Lichtman and Javed Moslehi, I've worked with on these topics and other topics for many years. I haven't done one of these before. So we'll kind of see how this goes. I'm not an immunologist, but we'll talk about immunology. I know some really good immunologists. I've been fortunate, and thank you for the topic paper suggestion. So if you like this topic, Peter's responsible. If you don't like it, then you can just blame me for having chosen it out of a menu of other choices. So what we'll do today is kind of go through the paper, give a brief introduction, grab some things from elsewhere in the literature as well. And then we'll go through really kind of the mechanisms of disease, which is what the paper goes through in a little more detail. We won't get too deep in the weeds, but enough that we can understand, I think, what we as pathologists would run into. And then we'll talk about some potential, knowing these mechanisms, then we'll talk about some therapies to treat myocarditis. And then they raise some questions at the end of the paper. And I have some other questions to pose to this group about, again, just kind of how we interact with this entity. So as people know, I'm sure this will be review for pretty much everyone, but just so we're all on the same page, the immune checkpoint inhibitors, their job really is to block receptors and ligands involved in T cell attenuation. So basically, we're taking the brakes off of the immune system and letting the immune system be as unfettered as it can, in the hopes that the immune system then will be able to fight whatever the patient's malignancy is that they've been getting the checkpoint inhibitor for. So the medications that are used, the current drugs that are on the market, I haven't listed them here, but they target either the CTLA4, the cytotoxic T lymphocyte-associated antigen 4, PD1 or PDL1, so programmed cell death protein 1 is PD1 and its ligand PDL1. And then one that is kind of newer on the scene, medications against this lymphocyte activation gene 3 or LAG3. Kind of all of these are meant to kind of dampen down the immune response, and so inhibiting those dampening down responses allows the immune system to be more aggressive. There's no such thing as a free lunch, so with these drugs, there's always adverse events, and so they're kind of labeled immune-mediated or immune-related adverse events, or IRAEs. And these generally relate to autoimmune phenomenon in various tissues and organs throughout the body. We'll talk about the heart here too. In my lung world, we see this as a pneumonitis often. There are other, throughout the rest of the body and all the lesser organs, there are also immune-mediated issues. Usually we see them after, often not after the first dose, but after the second dose, so kind of a month in after they've been maybe primed a little bit more. they'll develop some of these adverse related events, immune rate related events. Cardiovascular events, so myocarditis in particular, are actually in the kind of in the whole population of patients who are being treated with these immune checkpoint inhibitors is actually a fairly rare event. However, for the unfortunate patients who do suffer a cardiovascular adverse event, the mortality can be quite high. The risk factors, I'll go over some of them in the next couple slides. There's an increased risk of myocarditis with combination therapy when patients given more than one immune checkpoint inhibitor. So they're given both an anti-CTLA4 and an anti-PD1, for example, to really try to heighten the immune response is a big risk factor. And so what we'll do today, and what the paper does nicely, is they go through this concept of the checkpoint biology, not really discuss the preclinical models in a lot of detail, but talk about what we've learned from these preclinical models in various ways, and clinical samples from human patients, and go over the diagnosis and potential therapies for checkpoint myocarditis. So this is a kind of the box in their paper, really talking about the clinical side of the features of checkpoint myocarditis. So patients will often present when they have myocarditis with symptoms that one might see in myocarditis of any of any sort. So chest pain, dyspnea, fatigue, edema, lightheadedness, syncope, palpitations, all things related to generally inflammation within the myocardium that causes some sort of cardiac dysfunction. They can have arrhythmias that one can find on EKGs, Holter monitors, things. And then the serologic testing is really non-specific. They're looking just for elevated troponins for evidence that there's been myocardial damage, and then elevated BNP or NT-proBNP as a signal of heart failure. The imaging that they do is generally by MRI, cardiac MRI, using this Lake Louise criteria, which I'll briefly show you in the next slide. And then the question, and something that I've always been kind of interested in and curious about, is who actually gets myocarditis with checkpoints? Because we give checkpoint inhibitors to so many people, it would be great if we could tell, okay, who is this 1% ahead of time? Who is this 1% that's going to run into trouble? And we, might do something different or don't offer them that drug. Again, as I mentioned, there's multiple immune checkpoints being used. The cancer type, it seems that patients with thymic malignancies, with either metastatic thymomas or thymic carcinomas, will tend to have immune checkpoint mediated myocarditis more so than treating other sorts of tumors. The other tumor that occasionally we see in here is melanoma. Interesting, because melanoma tends to metastasize to the heart. It's a weird place that it goes, but we see that. And then again, in patients who have underlying potentially autoimmune processes like myositis or myasthenia gravis, again, going along kind of in the thymic realm, can be are individuals who have a increased risk of developing myocarditis. This is again, I pulled this from this paper in JACC from a few years ago, where they go over this Lake Louise criteria. So just so we can see as pathologists what the other side, the imagers, are seeing with their imaging. And the main criteria to make the clinical diagnosis of myocarditis is myocardial edema. So either on T2 mapping or the T2 weighted images from their sequences, if they see myocardial edema, it's one of the criteria. And then myocardial injury that doesn't follow a classic coronary distribution, which can be both abnormal T1 signal in again outside of a coronary distribution, increased extracellular volume, or late gadolinium enhancement with their studies. These are really the two main criteria. The other criteria would be systolic dysfunction, which we know and could play into already what we know about their clinical status and their NT-proBNP, for example. And then pericarditis, so either inflammation in the pericardium or pericardial effusion would be supportive criteria. So these are really what they use. We know as pathologists that these are not really non-specific criteria. There's nothing here that says this has to be myocarditis. There's no like specific marker for inflammation in the heart here. And these can be due to other non-inflammatory processes or processes that are not autoimmune in terms of causing myocarditis. When you look at the workup, and we won't go through all of this, but just to kind of make the point, that imaging is one part of their workup. So if the patient has clinical symptoms you mentioned that could be consistent with myocarditis, the heart failure and arrhythmias, palpitations, whatnot. If their EKG is normal and their troponin isn't elevated, then they have to think about other reasons for their symptoms. But the myocarditis workup generally includes this first bullet. I'm surprised didn't come a little earlier, but yet complete history and a physical, doing EKG and biomarkers to see if this is persistent, echo, MRI, and then here's where we would come in, plus or minus biopsy, and then looking for other associated pathologies that can go along with checkpoint myocarditis, like the myositis, the myasthenia that I mentioned earlier, and then make sure that this is also not, that the symptoms are not related to coronary artery disease. And patients with malignancy who are getting checkpoint inhibitors tend to be towards a little bit older, and so they may have coexisting coronary disease that may be completely unrelated to their tumor or to this therapy. So with that kind of as a brief introduction and already some kind of hopefully provocative thoughts or questions come to mind, let's talk about how this happens from a more basic science standpoint. So we'll talk about central tolerance, peripheral tolerance. We'll talk then about kind of how myocarditis, the thought of how this is happening and why this is happening, and then talk a little bit about the interaction between macrophages and T cells within the heart in the setting of myocarditis. So again, going back to medical school, central tolerance, the goal of central tolerance is to, or kind of the goal of the immune system in the thymus in general, is to produce T cells that are going to react against foreign antigens and not react against self. And it sounds like a pretty straightforward mission statement for what the thymus and the immune system is meant to do. And to recognize these foreign antigens in the context of presentation on MHC, either MHC class 1 for intracellular type pathogens or foreign entities, or things that have been taken up by macrophages or antigen presenting cells and going up on MHC class 2. So these immature T cells that are kind of waiting to be interrogated, if the immature T cell isn't able to even bind MHC very well or bind an MHC antigen complex, that cell will not get any survival signals. It'll undergo apoptosis. So these cells will be cleared from the circulation because they're just not good at their job in terms of recognizing MHC. If an immature T cell has higher affinity for MHC antigen complexes, these are then cells that are kind of in play that might be good cells to recognize foreign antigens. And so they are what are called positively selected. So they're good at something, they're going to be selected for it, and they will then commit to either being a CD4 positive cell or CD8 positive cell. If this gets messed up, the cells will get discarded at the next step. So they'll kind of differentiate into one or the other. And then they undergo, the cells that again are good at binding MHC and good at binding antigen, then they'll undergo this process of what's called negative selection. So this is where we hopefully weed out the T cells that have a T cell receptor against a self antigen. And so here, just in the diagram below, the thymic epithelial cells here are the ones that will be presenting antigen and the ones that will be weeding out the autoimmune cells. So for example, a thymic epithelial cell might express the gene for myosin heavy chain B. And so then if a T cell happens to come along that has a TCR that would recognize a self protein such as myosin heavy chain B beta, it will negatively select that cell, kill that cell will become apoptotic, and so we won't have an autoreactive clone floating around. So the cells that make it through then this negative selection after kind of being interrogated on the thymic epithelial cells are cells that should have a T cell receptor that will activate against something foreign, not activate against something self. And we'll also have some regulatory T cells that have kind of gone through that same process to dampen down the dampen down the immune response when needed. So these are now mature cells, and they can circulate and go off into the body and try to find their antigen to help us. So one of the ways that central tolerance can kind of break down is if the thymic epithelial cell actually doesn't express a self antigen or doesn't express a gene. And this actually does happen with myosin heavy chain alpha. So it turns out that the thymic epithelial cells don't produce this as a protein, don't put this up on MHC to interrogate the T cells. Why? We don't know. But it is a hole in the repertoire. Therefore, many individuals walk around, if they happen to have generated a T cell against this particular antigen that's expressed in the heart, may have autoreactive T cells already floating around that slip through the negative selection net, if you will. And so, in addition, other genes that aren't adequately expressed by thymic epithelial cells, one may have autoreactive T cells against those. You can also have autoreactive T cells if the mechanism, again, the negative selection mechanism may have failed. So you recognize the antigen, but you didn't get appropriate signals to undergo apoptosis. So that would be just that the less of a design flaw and more of just poor execution of actually negatively selecting a cell that should have been negatively selected. So this is all going on in the thymus. This is all going on early, generally more so very early in life. Then those cells that have been positively and negatively selected go out to try to find their antigen in the rest of the world. So, and this can happen in tissues. We think of it happening in lymph nodes quite a bit. So then our activated T cell with our T cell receptor will go off, and if an antigen presenting cell happens to to present that antigen, the active T cell docks, and along with co-stimulatory molecules that are expressed on a T cell, such as CD28, will interact with molecules such as CD80 and 86 on antigen-presenting cells, and then that T cell becomes activated. There is also a process for attenuating that response, and this is what's termed the immune checkpoint induction. So in many systems, when in the body, as we know, when there's an accelerator, there's usually also a mechanism that's a brake that kind of serves as a negative regulator. And that's the immune checkpoint, so-called immune checkpoint induction that we talk about here, where T cells will then put up on their surface a variety of molecules, including CTLA4 and LAG3. And these will, when interacting with antigen-presenting cells, will kind of dampen down that T cell activation. So we'll kind of provide a little bit of balance if CTLA4 is engaged and or LAG3 is engaged. CTLA4 engages with that same molecule that CD28 engages with, so there is a competition there of those two molecules. LAG3 has been more recently discovered. The ligand is not yet as well worked out. So you have now a T cell that's more attenuated. So this mechanism that we're going to be blocking with CTLA4 is going to keep cells more in that active state rather than in the inactive state. So another mechanism of peripheral tolerance, or a mechanism of peripheral tolerance, relates to these regulatory T cells. And this is just a panel, and we'll kind of go through these one by one. The point is these regulatory T cells are also meant to dampen down the T cell response, to dampen down the aggressive immune response against whatever the antigen is, just to kind of turn down the temperature a little bit. So regulatory T cells do this by a variety of mechanisms. One is that they can themselves produce anti-inflammatory cytokines. So TGF-beta and IL-10 are probably the two most common that will, kind of, again, dampen down the T cell response against an antigen. The regulatory T cells also talk to antigen-presenting cells, dendritic cells, and tell the dendritic cells to produce anti-inflammatory cytokines and anti-inflammatory molecules themselves. The regulatory T cells also have granzyme and perforin, like a CD8 positive cytotoxic T cell will have, and they can just directly kill effector T cells if needed. So kind of get them out of circulation. The regulatory T cells also can induce other T cells to acquire a regulatory T cell phenotype. Again, so if they want to turn down the heat, taking some of these T cells that were activated and giving them a more regulatory, or inducing them into a more regulatory T cell phenotype where they will carry out these other missions. Regulatory T cells also can serve as a sponge to sop up cytokines. So for example, IL-2, which is a survival signal for lymphocytes, molecule called CD25 on regulatory T cells, when highly expressed on those regulatory T cells, will kind of sop up extra IL-2 so that the IL-2 is no longer able to activate other T cells to increase the immune regulatory or the immune response, essentially. And then there's this interesting phenomenon of what's called phagocytosis, which basically involves the regulatory T cells stealing MHC and the co-regulatory molecules off of dendritic cells and kind of telling them just to stop doing their antigen presentation for a while, so as to not further incite more T cells coming onto the scene. So this is all going on at the level kind of the regulatory T cells having multiple different effects, but in general, just being able to dial back the immune response. The other mechanism of peripheral tolerance has to do more with the end user cells themselves. So any random nucleated cell, this could be a hepatocyte, this could be a cardiac myocyte, could be an endothelial cell, express this molecule PD1 or the ligand for the programmed death receptor on T cells. So PD1 is present in this diagram here, an activated T cell. If that activated T cell was going to go ahead and try to kill a nucleated cell, the nucleated cell can put up PD-L1 and basically say, stop, I'm not someone that you should be killing. I'm a normal cell. This is autoimmunity. Let's not do this. And so that's a way that the cell that was meant to be killed by that T cell can kind of dial things back and induce that peripheral tolerance. Cancer cells have figured out this trick. Some cancer cells have figured out this trick as a way to avoid the immune attack, and hence this is the kind of the interaction that the PD-L1 or the PD-1 blockers are meant to stop. So how does this relate to the heart? So PD-L1 is expressed on cardiac endothelium in the setting of inflammation that may be driven by interferon gamma. Again, if there's interferon gamma around, meaning to be an inflammatory environment, PD-L1 gets expressed on the endothelium because cardiac myocytes, I think from just an evolutionary standpoint, are not cells that we should be killing under just about any circumstances. And so the endothelium will help protect, if you're kind of thinking about why this mechanism might be in place, try to protect the cardiac endothelium at all costs. This is also played out in terms of this mechanism in some of them in the mouse models of myocarditis that we'll talk about in a second. So the PD-L1 knockout mice are more susceptible, not surprisingly, are more susceptible to myocarditis, even if you reconstitute their PD-L1 competency in bone marrow. So this is something, again, that's happening at the level of the tissue, the actual cardiac myocytes and endothelial cells themselves. So in addition to the endothelium expressing PD-L1, the cardiac myocytes themselves express PD-L1 in many inflammatory settings, including, kind of as to try to prevent acute cellular rejection in transplant patients in the transplant setting. They also will release, the myocytes can release these cardiakines that are reduced in mouse models and patient samples of myocarditis. So these are likely protective mechanisms that aren't protective enough in the setting of ICI myocarditis. So the preclinical models of checkpoint inhibitor myocarditis are not, we've learned from them, but they're not the most robust or the best models that we could see. So you would think an easy pharmacological model would just be, let's give the same drugs that we give to humans to animals and see what happens and look for myocarditis. It turns out that in a variety of strains of animals, of mice, that may or may not have tumors of various types. It doesn't really recapitulate the severity of what we see in checkpoint myocarditis. Some of the genetic models where you would knock out CTLA4 or knock out the equivalent of the PD1 gene are a little bit better, but there's, again, a wide variability in how well that mimics both the clinical phenotype of checkpoint myocarditis, as well as we know that individuals, patients with cancer who are getting these drugs, they don't have completely absent CTLA4 or PD1, PDL1 axes. So there's some variation there. The best model seems to be a heterozygous knockout of CTLA4 with a homozygous knockout of PDCB1. And there have been many mechanistic studies to try to elucidate the role of T cells, T regulatory cells, macrophages, natural killer cells, cytokines in these models. So some of what I showed you before, a lot of that we know from human data, but there's, it's also been shown in the setting of ICI myocarditis. So how do we think this works? So when immune checkpoint inhibitors are used, the peripheral tolerance mechanisms that we talked about are lost. And this increase is a good thing for trying to kill tumor cells, but it has the potential to lead to autoimmunity. And as I mentioned, in the setting of inflammation, PD-L1 is expressed on cardiac myocytes, and so the T cells and it prevents this PD-L1, PD-1 interaction, prevents the T cells from getting out into the cardiac tissue. So they don't leave the circulation, they just move on elsewhere. But in the setting of PD-L1 blockade, for example, that mechanism, that barrier is lost, and autoreactive T cells have the potential to make their way into cardiac tissue, interact with their CD8 positive T cells with the cardiac myocytes themselves, or interact with macrophages, antigen presenting cells in the heart to become activated and to be, to release pro-inflammatory cytokines that can call in more T cells and potentially more circulating monocytes to become macrophages within the tissue. And so it kind of at the level of the CD4 positive cells, there's more inflammatory cytokine production. The CD8 positive T cells, as I mentioned, if you have adequate PD-L1 on your cardiac myocytes, those myocytes will be spared because of that interaction. But if you block that, or if the particular cardiac myocyte becomes stressed and no longer expresses PD1 or PD-L1 on the surface, then that CD8 positive T cell, that autoreactive T cell, can go ahead and kill the cardiac myocytes. While this is going on, and we'll talk about the macrophages in a second, the CD8 positive T cells also can be kind of egged on by cytokines and growth factors that are cytokines in particular that are produced by macrophages as part of this macrophage T cell interaction dance. So kind of blowing up this part of the cartoon, we know that activated T cells will make interferon gamma. Interferon gamma pro-inflammatory molecule will bind to a receptor on a macrophage, and signaling through the JAK-STAT pathway will induce that macrophage to produce cytokines, so in this case CXCL9 and 10, that will interact with receptors on the activated T cell to cause them to produce more interferon gamma. And you'll end up in this loop, this kind of cycle of kind of self-stimulation and really ramping up the immune cell infiltrate within the myocardium if something isn't done to dampen down this process. So with that as kind of the basic mechanisms, how can we treat myocarditis? So the immune checkpoint myocarditis in particular. So the standard treatments are not very specific in terms of their actions. So the corticosteroids that are given, again, can dampen down the immune response a little, but very non-specifically. Mycophenolate, Mofetil, and ATG, antithymocyte globulin, again, kind of dampen down the immune response, but don't really get at some of the mechanisms that we've learned are important in immune checkpoint myocarditis specifically. So there are two medications that are used that are in trial now. This abatacept, which is a drug that's used already clinically on the market for rheumatoid arthritis, and it is a CTLA4 immunoglobulin fusion protein. It binds to that CD80-86 molecule on the antigen presenting cells, and it basically mimics the role of CTLA4. So it kind of gives back the function of CTLA4, where CTLA4 was one of the molecules that dampens down the immune response. This also, in addition to kind of engaging the T cell and calming it down, it also inhibits cytokine production by macrophages. So you get less of this loop between the macrophages and the T cells that kind of auto-stimulate each other. So that's one of the more mechanistically driven therapies that can be used to treat a patient who's known to have checkpoint myocarditis. And then the other molecule, this ruxolitinib, is a JAK-STAT pathway inhibitor. And so this will modulate the JAK-STAT pathway. And again, in that self-stimulatory cycle, will prevent the macrophages from responding to interferon gamma as aggressively, and they won't release these inflammatory cytokines as aggressively. So just in cartoon form, this is where kind of the abatacept and the ruxolitinib kind of come in, where steroids are going to hit a lot of different things, and CellCept and ATG are going to primarily hit the T cell. So they end the paper with a number of questions and some future directions. So thinking about, how can we are there better animal models? Can we refine the animal models to make them more accurately reflect the human disease? There are some immune checkpoint inhibitors on the horizon that target different immune modulatory agents, TIM3, for example. Will those have the same side effects, similar side effects, worse side effects? Question that I've always had with regards to this and other things is kind of how do the cardiac myocytes die, and when they do die, by what mechanism? Is it kind of the standard canonical CD8 positive T cell causing cell death, or is there something that's related to this inflammatory milieu in the heart? Clearly, we can see this as pathologists. The cytokine storm, harder to see as pathologists. And then really, I think for us, one of the questions is what is the role of biopsy? Is there a role for biopsy? How should we be kind of thinking about this with our clinical colleagues? And then can we, because we know there are some holes in the repertoire of that initial negative selection step, is there a way we can eliminate these autoreactive cells here? Just use the myosin heavy chain alpha chain to is the one that we know is not expressed, but there are likely others. Is there a way to, in a targeted way, remove those cells from patients who have them or who have them in abundance, and lower the incidence of checkpoint myocarditis? And so for me, the kind of the main two questions, or what I came away from this, is just what's the role of biopsy versus other things in diagnosis of this, and what people's experience have been. And then it does seem that when we get biopsies, and the biopsies are, quotation fingers, negative, we don't see a lot of inflammation, but these patients still have a lot of cardiac dysfunction, and they've ruled out other causes. Kind of, is there a role of these, as Dr. Mitchell would call these evil humors, cytokine storm, something inflammatory, but not cellular, attacking cells in the heart? And this kind of sort of goes along with some of the experience we have with AMR, where there's not really, cell death of the myocytes, but yet there's cardiac dysfunction, SARS-CoV-2 vaccines, other things where there's kind of variable amounts of inflammation we can see down the microscope, but the patients clearly have cardiac dysfunction. So those were kind of my review of the paper, and then kind of some additional thoughts, and hopefully I did that okay. And I'd love to hear more discussion and conversation surrounding these.
Thank you. Thank you, Rob. It's a very nice presentation, in depth and the mechanism related, and pinpoint the future direction for investigation and understanding. Thank you.
I have a question. Can you hear me, Bobby? It's Steve Cole.
Yep, I can.
So I think I know the answer, but does immune checkpoint inhibitor myocarditis look the same as regular myocarditis, viral, histologically?
So I would say in general, yes. So when we do see the pathology, it tends to be a lymphocyte, kind of a lymphocyte predominant inflammatory infiltrate within the heart with myocyte damage. We certainly, and probably many of us, have seen cases where it can even be more aggressive and can mimic. I've seen cases where it will look like a giant cell myocarditis, which is again probably the, at least as I think of it, kind of the extreme end of a lymphocytic myocarditis with with giant cells. But then we still, I still see these biopsies where they're convinced that there's myocarditis, and we don't see a lot of inflammation in the myocardium. And the question is this sampling, is this kind of sampling bias, or is there really not a brisk CD8 positive inflammatory response? And there's something about something about the local inflammatory milieu that's causing the cardiac myocytes not to die, but just not to function as well, not to contract or relax as well as they should. Is it related to the inflammatory cytokines? Is it related to the edema that we see? Vascular leak? Are there other kind of signaling molecules that are dampening down the the ability of the cardiac myocytes to actually contract?
I have another follow-up. So if you have a case of somebody who's on immune checkpoint inhibitors, they have a heart biopsy and it looks like, again, myocarditis, not otherwise specified. Would you call it or out and out diagnose it as myocarditis due to immune checkpoint inhibitor therapy, or just say myocarditis in patient with immune checkpoint inhibitor therapy? How strong would you be in your diagnosis?
So usually what I do is I sign it out just as lymphocytic myocarditis period C note, and then in a note say, and then that's also where kind of the being the clinician comes into it. So you go back through the history and you see when did they start the checkpoint therapy, when did their symptoms start, whatever, and then we'll usually in a note say, given the clinical scenario, the histologic findings are most consistent with immune checkpoint myocarditis, or are consistent with checkpoint myocarditis in this appropriate clinical setting, something like that. Because they're kind of leading with the first question, is there anything really specific you can say if you just have the slide in front of you without clinical history? I don't think you can sort out immune checkpoint mediated myocarditis from viral myocarditis from, for that matter, transplant rejection, cellular rejection in a transplant, if you didn't know that the patient had a heart transplant.
Yeah, great review. Thanks a lot.
Thanks, Steve. I'm not sure if I'm in charge here, but I'll call on I'll call on Charles. He's now in charge.
Great talk. I have read a few studies that claim, and I'm saying claim because I don't know if I've actually seen a true ICI myocarditis, but claim that it's characteristically, quote, open quote, close quote, histiocytic predominant. Has that been your experience, or do you have any comment on that? Like, to the point where maybe we could, push farther and say, actually, based on IHC and imagery, this, if we're looking at two possible causes, this would tip the scale towards ICI induced.
Yeah, so that's interesting. I haven't seen that in my experience. It's been, we definitely see a lymphocytic infiltrate. We see, definitely see macrophages. But I have to admit, I tend not to do it, I kind of call it based on the morphology. I tend not to do immunohistochemistry. So if I were to go back in, through the cases that I have, and again, this is not like I've seen 1,000 cases. That's certainly not the case. It's maybe, in the dozens or so. Could that be sorted out? That's a possibility. But I also think that there's such a wide variety in the number of macrophages you would see, even in a viral lymphocytic myocarditis, again, because of this dance that's hardwired into our immune system that the macrophages and the lymphocytes do, that you would see a range that I suspect would overlap, between viral myocarditis and checkpoint myocarditis. So I'm a little bit with you in that I'd be skeptical a little bit, and it may be just that we haven't either looked hard enough or looked in that same sort of way at viral processes or, to that. And then also, we know that patients with autoimmune disease can develop myocarditis. So take checkpoint, take cancer, all that out of it, but just patients with autoimmune diseases can develop myocarditis as a manifestation of their underlying autoimmune disease. And so I think there's going to be a spectrum of histologic changes. And with that one patient in front of you, N of one, I think it would be hard to sort them into a bucket without knowing the clinical history.
Yeah, good point. After the presentation, I'll just send you the couple of articles out of your interest. I'd be curious of your thoughts on it.
No, thanks. I appreciate that.
Hi, I'm Bihong in Houston, Texas. We have quite often have this kind of biopsy from MD Anderson. So there is all pure cancer patients. They just clinically suspect for myocarditis. Then they do the biopsy, they send it over to us to read. So basically every case has the lymphocytic infiltrate. We do the CD3, CD20, CD68, and the PD1. So that's standard. Every biopsy we do that. So it's pretty sure that's T cell predominant. So you have the CD3 positive T cells and the almost equal amount of CD68 positive histiocytes. Of course, we cannot quantitate them very accurately just by eyeball, probably equal histiocytes. Basically, no CD20 positive B cells, maybe one or two. Then always, we think that's quite unique as the PD1 is always expressed in both myocytes and the infiltrating lymphoid and infiltrating inflammation cells. So that's what we found. But I have not tried other myocarditis, viral myocarditis, even rejection, transplant heart rejection, CDL1 will be also expressed. I have not tried that yet, but I would like to see. Maybe in the future we'll do something to see that. That's what our experience is.
Interesting, Bill. So when you do biopsy, you said almost all the time you see the infiltration, right?
We have negative ones, positive ones, and severe ones, mild ones.
Gotcha. Thank you.
Yeah, not 100%. They suspect the myocarditis, but sometimes just negative, nothing.
Interesting.
We have I think we published together with MD Anderson people. We published one paper on this myocarditis. We try to grade them, grade 1, grade 2, grade 3 by field of lymphocyte infiltrate. Yeah, we quite frequently see that. That's because I'm MD Anderson.
Yeah, we see so here we're still, at least for the time being, we're still the pathology department for Dana-Farber. So that's where kind of the patients that we end up seeing. I do wonder with this experience, if and how it would change management of I mean, clearly stopping the checkpoint inhibitor, that's the easy.
Right.
But if you have thinking about the grading that you just described, that if something has, if an infiltrate is more mild versus an infiltrate is more aggressive, if that might impact, which of these therapies they may go after. Because if you don't have a lot of T cells in your infiltrate, if it's a very mild infiltrate, giving, potentially anti-T cell therapies might not be as effective in, in halting the myocarditis. If it's a more humoral cytokine driven inflammatory process, maybe that, either corticosteroids or some of the other drugs that will inhibit cytokine production might be more effective. I think that's a second order question, but it'll be interesting to know what your clinicians might do with that information. Or is it still in just information gathering mode, which is also obviously completely legitimate?
I think the first thing they do, they just stop the medication. Then after that, what's next? I think they have to correlate with the patient's general health issue and how bad the heart, the the heart failure or the symptoms the patient have. So I think that I know stop medication is one. Stop for a while. If the troponin level dropped, the heart function comes back, they can start over, try again, or try different kind of inhibitors.
Yeah, Rob, you mentioned that in the heavy chain 6 or something, is not activated, tolerated by T cell. So somehow, so if that's the case, I mean, how can we see approach that will not trigger immune response?
Right. So you would think that, I mean, based on what I presented, that, if we all have this hole in our repertoire, we should all be developing autoimmune myocarditis. But that's where the peripheral tolerance comes in. That's where, kind of the PD1 expression on endothelial cells and cardiac myocytes basically tells these cells, no, we're friend, not foe, even though you're against us. And at kind of at the level of the tissue, and then at the kind of the priming level within the lymph node, also you have these regulatory mechanisms, and you have regulatory T cells that will dampen down the response in a setting where there's not otherwise inflammation or damage to kind of say, no, don't get excited, here's nothing to see. So there we do have kind of baked in these mechanisms, but it is in kind of that one of the kind of questions, or one of the thoughts that I posed was, how is there a way we can know if my anti-heavy chain antibody T cell is much more aggressive than yours is, and so I'd be more at risk than you would be, if there's a way to kind of assay that out. So that, I mean, that would be kind of potential, but thankfully we do have several mechanisms and redundant mechanisms and it may be that that one of us never developed a T cell that would recognize that particular antigen, self-antigen, just because this is such a stochastic process in terms of developing T cells and developing a kind of a T cell repertoire. So there's, I think, a lot of potential reasons why we don't all have autoimmune disease in that way.
Yeah, even after PD-L1 therapy, right? So you still have that somebody have this, somebody don't express that way. But sounds like there are many unknowns. Any more questions? Or if not, I think it's a very good discussion. I think Qing Yu have several questions posted in the chat. You want to comment on any one of them, Rob?
I would just say, in terms of kind of it looks like it's kind of macrophage driven, and the questions are related to macrophages. And I do think that, again, that kind of dance between the lymphocytes and the macrophages are important. And and again, in doing, and probably all of us had this experience in doing, kind of COVID autopsies. I only saw one case of a legit lymphocytic myocarditis due to COVID, but had plenty of patients where there was heart failure as part of this, probably the kind of systemic inflammatory response. And so the cells, the macrophages that are there in the heart may be, amped up, revved up, and will recruit in some T cells and some macrophages, but not enough that we as pathologists would diagnose that as myocarditis. So it's a immunologic process and an inflammatory process, but it's not a T cell killing myocyte type process. And so that may, relate, in my, kind of my bias is that relates to, the lack of a lot of cells, but slightly increased cells, macrophages above baseline. And it may be that, as I think Christina pointed out, that there are other more systemic inflammatory processes that do lead to cardiac dysfunction and cardiac failure, and that kind of the circulating inflammatory milieu is what's driving it. But mechanistically, I think there's still there's still questions about exactly how and why that happens.
So Fallon asked a question, any transcriptomics done?
Not that I'm aware of. I don't recall them. I think they did point out in the paper that there are other ways to kind of use patient samples, or thinking about with having fresh tissue and being able to see what's been done. There, I think the challenge is knowing from which cells the transcripts are going to be arising from. Is it a macrophage that's producing something, or an endothelial cell, or cardiac myocyte, or a T cell, I think. So having the spatial part of that is, would be important from a mechanistic standpoint to try to sort those things out.
Thank you so much. Like everybody pointed out, excellent review. And I think more questions will send to you. I hope you have time to answer.
Me too. I think there is a light at the end of the tunnel. So, but at least for everyone here that I know, this is indeed proof of life. I still exist, and looking forward to seeing everyone in Boston this spring.
Thank you.
All right. Bye. Take care,
Adios.
everyone.
Bye.
Thanks.
Great talk.